Welcome to This Explainer. If you're a medical professional, especially an otologist or a dentist, you have absolutely seen this patient. They sit in your chair complaining of intense ear pain, fullness, or ringing, and yet when you look inside, their ears look perfectly, flawlessly healthy. Well, today we're going to decode exactly why that happens and explore the fascinating anatomical and pathological links between the jaw and the ear.
So let's just dive right into the big question. Why do so many of these cases of idiopathic tinnitus, ear fullness, and otalgia completely resist our standard otologic treatments? You know the drill. A patient comes in reporting severe subjective hearing loss. You do the standard audiogram, you do the visual inspection, and there is absolutely zero evidence of primary otologic disease. It's incredibly frustrating, right? So where exactly are we supposed to look next? Today we're unpacking the exact biomechanical mechanisms proving that the TMJ and the ear basically act as a single contiguous biological unit. We're going to quickly cover the diagnostic blind spot, the legacy of Meckel's cartilage, anatomical cross-wiring, neuroinflammation, and how to effectively diagnose TMD in otology. All right, let's start with section 1, the diagnostic blind spot, and those medically unexplained symptoms.
Historically, when we couldn't find an organic cause for symptoms like subjective deafness or ear pain, they were often just chalked up to conversion disorder. If a patient was stressed out, we just assumed it was, somewhat psychological. But here's the critical pivot in our modern understanding. While stress is for sure a major factor, it actually acts as a trigger for very real physical conditions like bruxism or teeth grinding. And that grinding, it creates highly tangible biomechanical microtrauma and inflammation right there in the TMJ, which then refers very real physical pain directly to the ear.
Have you ever heard of Costin syndrome? This is really what set the clinical precedent that auditory and vestibular symptoms can stem directly from the jaw. Just imagine a patient complaining of a blocked ear, vertigo, and subjective hearing loss, but structurally their ear anatomy is flawless. Thanks to modern objective audiometric and vestibular function tests, we now have the proof that these exact symptoms often originate directly from temporal mandibular disorders or TMD.
Moving on to section 2, Meckel's cartilage legacy and our shared origin.
To really grasp why this happens, we have to zoom out and look at our embryology. The secret is completely in our shared wiring. The mandible and the middle ear ossicles actually evolve from the exact same embryonic structure, Meckel's cartilage. In the embryo, this forms the first branchial arch. Then, as the fetus develops, the posterior portion of that cartilage transforms directly into the malleus and incus of the middle ear. It's only later on in fetal development that the temporal bone forms and actually separates the masticatory and hearing organs into two distinct compartments. They are literally born from the exact same tissue. Which naturally brings us to section 3, anatomical and neural cross-wiring.
Let's look at the microanatomy to see how this translates into clinical pathology. There is a direct biomechanical link here via the petrotympanic fissure. The discomalleolar ligament connects the sheath of the lateral parapterygoid jaw muscle directly to the malleus in the ear. So when your patient has an anterior disc displacement in their TMJ, it creates a tension that literally pulls on this ligament. Now, this pull only moves the malleus by mere microns. But, as we know, in the delicate middle ear, microns absolutely matter. That tiny movement is enough to stiffen the middle ear system, transmit to the stapes, and completely alter the polarization of inner ear hair cells. It's a chain reaction, providing a highly plausible mechanical explanation for why a jaw issue causes a ringing or full sensation in the ear.
And honestly, it gets even wilder. Take the tensor tympani, the muscle sitting just above the eustachian tube that controls tympanic membrane tension. It is actually considered in the literature as a strange chewing muscle. Why? Because it's innervated by the mandibular nerve. So when a patient is super stressed and has mascatory muscle hyperactivity, like they're constantly clenching their jaw, that increased central nervous system tone also causes contraction of the tensor tympani. This directly links jaw muscle hyperactivity to that incredibly frustrating symptom of ear fullness. Let's transition to section 4, neuroinflammation and shared pathology. Beyond the physical pull of ligaments, we have to talk about inflammation, and we can contrast two types here. On one hand, you have low-grade inflammation from everyday teeth grinding, which releases inflammatory molecules that sensitize pain receptors. On the other hand, you have high-grade inflammation, like rheumatoid arthritis, where synovial pannus just aggressively destroys TMJ structures. And the numbers here are wild. Studies show that adults with rheumatoid arthritis of the TMJ have remarkably high incidences of otologic symptoms. We're talking about nearly 55% experiencing ear pain, almost half dealing with subjective tinnitus, and over 64% experiencing vertigo. As you can see detailed in this comprehensive review from Juniper Publishers, authored by Dr. Kamal Giafat, it isn't just local inflammation causing these issues. Neuroinflammation and maladaptive plasticity in the central nervous system play a massive, essential role in maintaining these chronic otologic symptoms. The brain literally rewires how it processes input from the inner ear simply because of the constant inflammatory signals coming from the neighboring jaw joint. So why does this referral happen so easily? Well, it's all about the neurological map. The sensory nerve supply to both the TMJ and the external ear comes from the exact same source, the auriculotemporal nerve. Plus, the nociceptive or pain-sensing nerve fibers from both regions literally converge onto the subnucleus caudalis in the brainstem. Because of this neural convergence, the brain just gets confused. It can't always clearly distinguish where the pain is actually coming from. So TMJ pain, or masticatory muscle entrapment of that nerve, is frequently and easily referred to the ear as a severe shock-like pain. All right, finally, let's hit section 5, diagnosing TMD in clinical otology. So how do we actually spot this shared pathology in daily practice? One brilliant, very effective technique mentioned in the literature is joint vibration analysis, or JVA. It's a simple screening tool that categorizes joint sounds based on vibration frequency. And why does a jaw sound matter for the ear? Because abnormal TMJ sounds, like the clicking of a displaced disc or the crepitus of a degenerating joint, actually transmit directly to the neighboring cochlea via soft tissue conduction, traveling right down the vascularized retrodiscal tissue and the Eustachian tube. JVA perfectly bridges the gap between simple clinical findings and highly complex imaging. Now take a look at this breakdown. It's absolutely crucial for distinguishing TMD-related ear pain from primary otologic disease. Notice how your TMD patients will sit in your clinic with a perfectly healthy tympanic membrane and a completely normal audiogram, yet they are complaining of severe subjective fullness. So instead of looking deeper and deeper into the ear, feel the jaw. You'll often find clicking or crepitus, severe masticatory muscle pain when you palpate, and referred auriculotemporal pain that often manifests as a temple headache. Once you connect the dots and identify that the tinnitus or otalgia is actually originating from the temporal mandibular joint, the entire treatment paradigm shifts. It's a real game changer. You focus on the jaw. We're talking custom oral appliances or mouth guards to effectively reposition the jaw and take the pressure off the TMJ and those delicate connected ligaments. We're talking targeted physical therapy to resolve muscle spasms and stress management to stop the bruxism that's triggering the whole shebang. Alleviating that jaw pressure can dramatically, and I mean dramatically, resolve the ringing in the ears. So keeping all of this incredible anatomical shared wiring in mind, how will you change your intake assessments tomorrow? When your next patient presents with unexplained ear fullness or ringing, but their ear canal is absolutely pristine, will you remember to check the joint right next door? The ear and the jaw are essentially a single unit, and treating them as such might just be the key to solving your most frustrating clinical mysteries. Thanks so much for joining me on this explainer.